Hypoglycemia is defined as low plasma glucose causing symptoms, confirmed by triad. Whipple's triad includes symptoms of hypoglycemia, documented low plasma glucose, relief after glucose administration. Normal fasting plasma glucose is at least 70 milligrams per deciliter or 39 millimoles per liter. Severe hypoglycemia can lead to confusion, seizures, cardiovascular events, and death. The brain depends on a continuous glucose supply and cannot store glucose. During fasting, glucose is maintained by hepatic glycogenolysis for about 8 hours. After glycogen depletion, gluconeogenesis provides glucose from amino acids and glycerol. Counterregulation begins with a fall in insulin levels as the first defense. Glucagon rises next to increase hepatic glucose output. Epinephrine is the third defense and produces autonomic warning symptoms. Cortisol and growth hormone act during prolonged hypoglycemia. Behavioral response includes ingestion of food to correct hypoglycemia. Neuroglycopenic symptoms include confusion, fatigue, seizures, and loss of consciousness. Autonomic symptoms include palpitations, tremor, anxiety, sweating, hunger, and paresthesia. Common signs include diaphoresis, pallor, and increased heart rate and blood pressure. In recurrent hypoglycemia, warning signs may be absent due to autonomic failure. In diabetes, hypoglycemia is a major limiting factor in glycemic control, especially in type 1 diabetes mellitus. Risk factors include excess insulin or secretagogues and missed meals. Exercise increases glucose utilization and raises hypoglycemia risk. Alcohol reduces hepatic glucose production by blocking gluconeogenesis. Renal failure reduces insulin clearance and increases hypoglycemia risk. Hypoglycemia-associated autonomic failure leads to reduced glucagon and epinephrine response. This causes hypoglycemia unawareness and increases the risk of severe episodes. Management includes strict avoidance of hypoglycemia for 2 to 3 weeks. Use of basal and prandial insulin analogs improves safety. Continuous glucose monitoring and insulin pumps reduce episodes. Structured patient education is essential for prevention. In non-diabetic patients, drugs such as insulin and sulfonylureas can cause hypoglycemia. Critical illness including liver, renal, and cardiac failure can precipitate hypoglycemia. Hormone deficiencies such as cortisol deficiency and growth hormone deficiency are important causes. Endogenous hyperinsulinism includes insulinoma and functional beta cell disorders. During hypoglycemia below 55 milligrams per deciliter, insulin levels are at least 3 microunits per milliliter. C-peptide is at least 0.6 nanograms per milliliter and proinsulin is at least 5 picomoles per liter. Beta-hydroxybutyrate is suppressed at 2.7 millimoles per liter or less. Glucose rises by more than 25 milligrams per deciliter after intravenous glucagon. Imaging with computed tomography or magnetic resonance imaging detects most insulinomas. Endoscopic ultrasound detects about 90% of tumors. Definitive treatment of solitary insulinoma is surgical resection. Unresectable cases are treated with diazoxide, octreotide, or everolimus. Clinical takeaway is that hypoglycemia is common, dangerous, and often preventable with structured care.